as you might have seen, if you look at this X-ray, this X-ray image, and look at this CT image, you can see what I was talking about, the ability to trap the X-rays as they go through the bone mass gets more accentuated, gets much better seen in terms of what we call the resolution than it is on the X-rays, because here you're looking at the slide thickness, and in this our slices get thinner, and therefore the ability of the eyes to see what you need to see gets even much better. So you can see what we are talking about. The lucencies are much well visualized. The vertical trabeculae are more prominent, and you can see that the transverse trabeculae are actually decreased across the board. So there you started talking about seeing what they were explaining clinically into radio diagnostic image receptors. So exactly this is what we are trying again to talk about. The bone formation and bone resorption are being mismatched. And so you're having prominence of the bone resorption part that is more prominent. So decreased bone marrow, bone mass densitometry increases the likelihood of osteoporotic fractures. And I think Prof. Alex talked about where these fractures are common and most likely why. As we walk vertically standing, the axial loading plays a significant role, and that's probably why one would explain why most of the tests in terms of trying to agree on where to look for osteoporosis have come with agreement that the best sites would be the spine, pelvis, and particularly the femoral neck and head, then clavicles, scapula, ribs, particularly as men get older, and the females actually as well. So imaging appearance of the spine, what do we look for? You're looking at non-fractured or non-fracture changes, vertebral fractures, non-fracture changes, where we are seeing the coarse trabeculations that become of striated appearance. So the cortical thinning that we talked about, which can be more appreciated on the lateral X-ray per se, as opposed to the AP, because you've got a lot of artifacts from the adjacent organs. So the loss of trabecular density, thinning of linear shadow of the vertebral cortices become accentuated, generated, and generate the ghost vertebral appearance. So as we are talking about this trabecular pattern in reference to what Professor Randolph talked about, where you have this resorption going beyond the new bone formation, you actually get what we call the ghost hemangiomas or vertebral hemangiomas. So you have these lucencies within the vertebral body that actually get termed as ghost vertebra, as we shall see. So as they said, the hallmark of treatment and the ultimate objective for treatment is to actually halt the progression of osteoporosis such that you prevent fractures. So when you're able to prevent fractures, and there are so many modifiable and non-modifiable risks for these osteoporotic fractures, you then have played a significant role in trying to protect our beloved patients. Let me go to how osteoporosis is seen in CT. So maybe, I don't know whether he said it, when we are trying to image osteoporotic bones, there is what we call qualitative assessments and quantitative assessments. And understandably, when you're doing quantitative assessment, you're trying to actually approximate the bone mass. And when you're doing the qualitative assessment, then you're trying to see if indeed the quality of the bone is to the best it could be, or it's just brutal or fractured sclerotic bone. This bone would look this one. You can see, if you look at this vertebra and look at this and look at this and then look at this as well, because these posterior elements, as Prof. Alex talked about, if they are not stable, then the patient also loses stability. And most of these things could actually find somebody that was measuring 1.8 is about 1.5, and you wonder whether somebody is trying to sink. Or so we are now clearly seeing the trabeculae that we are talking about. So you understandably, I think we can see that you can easily, on the QCT or quantitative CT, easily see that osteoporosis is much more pronounced. Do we see this most of the times? Does it ring a bell in terms of alerting our clinicians? Probably not, as we are supposed to do. And I guess as we thank Dr. Subira, this is critically important, such that if I see this, or if JP sees this, you alert your counterpart, such that this patient's back is protected, this patient's femur is protected. Otherwise, you're just doing work as if you are a reporter, not a doctor. Yes, yes. Or probably not a leader, because if you have to talk to your colleagues and agree on the best way forward. This one, we are managing the queue. So we become managers, good managers. You scanned 50 patients, good, the hospital benefited. But you haven't done much more than you could have done. Probably this is the hallmark finding of what we talk about. And maybe we could share the terms we normally use, the codfish, fish mouse, hourglass appearance. But all in all, this is what we are trying to explain. And this, I think, will play a significant role to when we teach our residents. And part of the core values we bring in is the multidisciplinary team and the multidisciplinary practice. If you see this, don't say that this is end-plate fracture, but we need to report that this patient has got a wedge fracture and multi-level, and therefore the orthopedic surgeons or the spine surgeons need to do more than they are probably doing. I will talk about briefly what we call the bone mass quantification on MRI. We are lucky we have MRI here. We have about 6 magnets in the country. It's something to understand that there are some good things that we can do with X-rays, with DEXA scan. I'll talk about DEXA scan in a few seconds. But we also have this, and there are some tools actually that are now available that could be shared across, and we help our patients, which is the ultimate objective of multidisciplinary clinical practice. If you look at this bone and look at this one, you can actually see MRI somehow exaggerates, but is not exaggerating. It is showing it much more. So as we saw that inflammation plays a significant role, here in this compression fracture, initially you have this compression that cascades pathophysiologically into so many processes. So you have the inflammation, which is why on T2 you have this water-like signal. It is called high signal intensity on T2. So it is picking more water compared to other fibrous tissues or bony tissues, as you can see. So you're getting much better signal here than here because there is probably some fluid. And since we are not teaching only radiologists, I can see, thank you, colleague radiologists that have come here. Now we are talking about the bones, but you can see that this vertebra that has collapsed is actually causing cord compression. So this becomes an emergency for spinal surgeons, for physiotherapists, and it's critically important that it's not only bad enough to lose the signal, it's not only bad enough to have a fracture, but it's bad enough actually to have this patient unable to pass stool, to control urine passing, and so on and so forth. So the problem is real, and the problem is actually worse. So this one, I think, is just to add to what Professor Butera was talking about. And since we are going to share these slides, I will allow for probably discussions. But the pathophysiologic mechanisms of why we get more fractures in the head of the in the neck of the femur, in the spine, and what we call the flagellated fractures that you see in the calcaneus and other pressure bones. I think he explained more, and I won't take much of your time as well. Based on the predictable sequence of evolution of trabecular radiographic scale for diagnosis, this is what we do. We have what we call the Singh index. And Singh index, majority of us being healthcare professionals, we understand that this is a classification criteria that has been developed by Singh, and essentially based on the predictable sequence of evolution, how things are likely to proceed to the worst case scenario of having fractures. This is what takes place. And when you grade, unlike other grades, grade 6 is where you're talking about normal bone, and grade 1 is where you're talking about principal compressive trabecularly that potentially result into fractures. This one people can read, and I'll talk about this isotope scan. They say it's the most sensitive method for detecting stress fractures. I think we need to understand that very soon, probably not more than 12 months. I heard the minister talking about that it is being manufactured particularly for Rwanda. So we shall be having this, and we are going to see what we call the Honda sign. In radiology, we love science. And when you talk about science, then you sound more educated, even when you're not. So I hope I'm not scaring anyone, but so the common patterns at bone scintigrams, particularly in sacral insufficiency, fractures that are H pattern. And for those of us that are involved in imaging, sacrum is part of the body that is difficult to image, particularly on projectional imaging modalities. So from bilateral fracture through sacral ala are connected by transverse fracture through the sacral body, and in pattern. So this is what we call your Honda sign. Those of you who drive Honda know what Honda sign means. Yes. So you may have non-hip appendicular skeletal fractures, and these ones, as we said, could be modified by different conditions. In arthritic conditions, which could be inflammatory or non-inflammatory, and those ones as well depict typical bone loss at different sites. And periarticular, proximal, mid, or distal, this has got a significant meaning for those people that are involved in imaging. If you talk about rheumatoid arthritis, you typically know how it presents and which articulating portions of the bones are going to be involved. Calcaneus, for same reason that he explained, it is an optimal site for morphologic evaluation of trabecular pattern. Calcaneus has compression and tensile trabeculae, and we have fractures, fragility fractures, stress fractures around this bone. And as you can see, even when they are going to assess, as we are going to see, when you do QCT, there is CT, there is ultrasound, there is MRI. Even when we do ultrasound of the bone, it is actually good because it is peripheral and very easy to send your ultrasonic beam. So you can have diffuse osteoporosis, you can have regional, you can have focal osteoporosis, and so on and so forth. And for reasons actually that have been explained, these ones are understandable. I saw we have about 15 minutes. I hope I have finished 10. DXA uses an X-ray source. Since we have to make George very happy, we have to talk about DXA. DXA and the technical aspects. Dr. Subira introduced George, and George was so generous to host this evening, and they have a very good DXA machine, and DXA that uses an X-ray source that has got essentially two distinct energies. You have the high and low energies. And by using computer analysis, the software, the soft tissue contribution to the measured density is eliminated, allowing the measurement of bone mineral densitometry. So to produce the dual energies, this is again a bit difficult in terms of physics explanation, but we have dual energies that are sent in, and we have different analytical models that are used by the softwares in these machines that help us make the images, and then you have the display. So the K age is the energy level at which the maximum amount of photon is absorbed by particular tissue, and DXA systems were mainly essentially pencil beam. Most current systems are fan beam, allowing the faster scanning. I think somebody is going to talk about these DXA machines and how, according to modern science, how these DXAs have evolved. Prof. Alex talked about T and Z scores, which I think when you want to be complex, we use these scores. So I want to talk about it briefly and then come to the conclusion. In postmenopausal women and elderly men, the T-score is used to stratify patients into one of the following categories. Essentially, you scan a patient because the patient has got back pain and you're probably suspecting osteoporosis. So we talk about, as you're going to see, so there is normal, there is osteopenia, and there is osteoporosis. So when do we talk about osteopenia? When do we talk about osteoporosis? So this is an image that is generated, software facilitated, and an example is this 48 years old woman who had a T-score of -1.2. in the osteopenic range. So this is what comes out, and this, by the way, is a gold standard imaging so far that has been agreed and accepted by the World Health Organization. So when you talk about T and Z scores as done by the DXA or by CT, CT, DXA has been regarded as a gold standard. So this is, you mainly, you can calculate this from L1, 2, 3, 4, and this is what you get out. So you have the responsibility to say that this bone that I have assessed is normal, it has a normal density, and therefore ranges from +1 to 0, or to -1, sorry, or is osteopenic. Osteopenic is again between -1 and -2, and anything that is more than 0.25, -2.25, we talk about osteoporotic bone. So again, this is essentially, you talked about normal, low bone mass or osteopenia, and then osteoporosis, and this is the lowest BMD measurement to make the diagnosis. So it is from this. The more you go here, this is normal. The more you go here, this is osteoporotic bone. So again, this I think has been talked about, but essentially if you have anything to remember, remember that we have got what we call T and Z scores. And T scores, essentially, you're looking at a number of standard deviations from normal. Negatively, positively. So number of standard deviations from the mean bone density values in the normal sex matched young adults, and we know how this is calculated. You have got a number of cases that have been done, and the people that were found to be normal bone mass are like this. Those that have been found to be osteopenic are in this category, and those that have been found to be osteoporotic are in that category. So used to make the diagnosis of osteopenia and osteoporosis, Z-score is the number of standard deviations from the normal mean bone density value for age and sex-matched controls. So please mark the difference. And if it is lower than -2, then you may suggest the presence of secondary cause of osteoporosis, and it is essentially used to assess the bone loss in premenopausal women, I beg your pardon. So this again has been talked about. The disadvantage is that this is a two-dimensional imaging modality for a 3D anatomy. We are a 3D anatomy. The DXA is a projectional imaging modality. So you have a 2D representation of a 3D anatomy, and there is a likelihood that actually you might miss something that is worth important. So it measures the density and area not volumetric density like CT. Spine and hip, DXA are sensitive to degenerative changes, and individuals with substantial degenerative disease will have increased a real density, which suggests lower fracture risk than is actually meant. So I don't know whether you understand this, but this is what it means. DXA has a limitation in measuring BMD in patients with body mass index over 25 kilograms. I think we saw what obesity plays in actually modifying osteoporosis because of different reasons. Fat, estrogen, probably addition to the bone mass. So in obese patients, superimposed soft tissue will elevate measured BMD owing to attenuation of the X-ray beams and what we call the beam hardening artifacts. These are essentially artifactual. So the quantitative CT, again, I think we talked about it, but again, this one is at least a 3D representation of a normal human anatomy, and it would be easily accessible to the trabeculae as they are arranged in the normal vertebra or in the osteoporotic vertebra. So it allows true volumetric measurements of the lumbar spine and proximal femur, which are independent of the body size. And the issues of beam hardening artifacts is actually relatively decreased because you're sending in regulated X-rays, you are thin slicing the body, and therefore you're likely to overcome both actually volume averaging and beam hardening. So it provides purely trabecular bone measurements which are more sensitive to monitoring changes with disease and therapy. Cross-sectional studies have shown that quantitative CT-BMD of the spine allows better discrimination of individuals with the fragility or the stress fractures as we saw. This one again is almost actually the same. It's only that the difference applies to different parts of the body, the calcaneus that we're talking about, and so on and so forth. Ultrasound, just to bring to your notice that ultrasound is an integral component of imaging of the bone, particularly if you're assessing the quantitative part. And we did a study on the bone densitometry and the ARVs, and it actually was in agreement with so many findings in the quantitative analysis of the bone, of the BMD, and so we probably need to have the access to the probe and the technique. So these quantitative ultrasound parameters associated with material properties of trabecular bone. In addition, you assess the density. These variables reflect parameters such as the elasticity and micro architecture of the bone. So the speed of sound decreases in osteoporotic bone, and broadband ultrasound attenuation increases in I don't know whether that is very important, really, this image formation, but this one is the beauty of MRI, and believe you me, King Faisal Hospital has got a very good MRI, and probably we might have this software installed, so where you can have MRI-based quantitative osteoporosis. So this is a quantitative, it's a quantitative bone marrow densitometer, and there are softwares. If those of you that have seen what Dr. Skube has done, he has made a significant comparison between these bone marrow changes, marginal osteophytes, end-plate sclerosis, and essentially the trabeculae in the vertebra alignment on MRI and CT. We shall share this, and probably one can find out this. So what we do in MRI quantitative bone marrow densitometer is that we take a number of calculations from the vertebral body and consider the signal intensity in the CSF space on T1 non-enhanced imaging, and then we do a range evaluation. I'll put what we do and how it is done. To spare you your time, I would like to conclude and say osteoporosis is a severe debilitating disease condition, as has been demonstrated by colleagues. And we need to understand that it affects all age groups, all sex groups. But again, we have seen clearly that females and menopause women are majorly affected for reasons that have been clearly explained. And diagnosis and monitoring of osteoporosis using quantitative techniques such as DXA can help us big time. And to say that we have got different imaging modalities at our disposal to be able to come up with standardized reporting patterns for osteoporosis for any age groups, but majorly for our osteoporotic menopausal women. Thank you very much.
Friends, you will agree with me that we have been wasting a lot of treasures here. Talking about this very important topic. not using them is wasting them. We should be using you, sir. We should be using you and you when you're around. But Dr. Hannah is there as an endocrinologist. Just step in. Thank you very much for this kind of a good presentation. It was fantastic. Actually, the idea behind the whole thing is that it couldn't be a better time to think of starting a clinic of menopause. It's the right time to start the menopause clinic at King Fahd Hospital. With the resources we have, with the brains we have here, we can't choose a better time to start this clinic. But meanwhile, today, we sinned profoundly. We're politically incorrect because we didn't have any woman presenting today here. So we apologize very much. Next time we'll give you a whole presentation scene, okay? Well, sorry. Mea culpa, mea maxima culpa. Okay, so at this juncture, we've got orthopedic surgeons, we've got imaging specialists, we've got even pediatricians. So the space is open for comments, for questions, for observations. And after that, we'll have just a small talk from GE representative, and then we'll go out for refreshment. Any observations? Any comments about the presentations which have been made? Oh, before you come, I've heard about self-assessing osteoporosis by women here. Do you allow people to assess themselves? Have you heard about that? Or am I too old to read? Nothing. Forget it then. Your question, sir.
Thank you. It's just maybe I'm just looking for a clarification from Professor Randall. Dr. Michael, I'm a gynecologist obstetrician practicing. So for me, is most of the patients present with vasomotor symptoms. So they are more worried about that. And we know osteoporosis is silent. Now, when you are treating, is there how do you strike a balance if you want to treat vasomotor symptoms, at the same time prevent future fractures? So maybe that is in terms of practice, or do we have to routinely associate with calcium, vitamin D during the time we are?
Sure. Yes. Yeah. Thank you so much. Should I get those microphone? Yeah.
Yeah, I believe the question is if you're treating a menopausal woman with vasomotor symptoms, then what?
Yeah, like how do you, at the same time you're managing vasomotor symptoms, and then you also want to prevent, future osteoporosis?
Right. In terms of, do you need adjunct? I think first thing is that everybody should be on calcium and vitamin D. That's sort of just that's the background. Just in terms of whether it's dietary or whether it's supplemental, but that's an important thing to make sure that they're in. So that's a basic part. And the other thing that's the nice thing about hormone therapy is that, as I mentioned earlier, that typically it takes more estrogen to treat the vasomotor symptoms, and you're automatically providing anti-resorptive therapy by doing that. And so therapy is being treated to try to reduce the bone loss from that. And I think we kind of went through quickly in terms of screening, that all women should be screened by age 65 unless they have a risk factor that suggests earlier screening, and typically that's with DEXA scans because that's the gold standard for looking for presence of osteoporosis. But the practical answer is if you're treating the symptoms, then you're also treating her bones. That's the nice thing, it's automatic.
I think it was just the question of the dosage maybe, and How much is supposed to give?
Yeah.
You know?
And typically, if it's enough to treat the vasomotor symptoms, you're getting the anti-resorptive effect, because it doesn't take that much to get the anti-resorptive effect. So whatever you choose, or whatever she chooses. Yeah.
Question behind you, Prof.
I'm sorry, it's from the pediatrician, so that's the best part to ask about menopause. Thank you, quite interesting, but I just have two questions to many of the orthopedists, but also the imaging. One, is there a standard screening period? It should be, say, at this age, this period of time, we do that. So these are things that we discover incidentally when we are looking into other solutions. I may have missed it, so I kept moving in and out. It's very important. We all have mothers and other people that we need to advise. Two, Professor Chema shared a couple of different modalities of imaging, but I want clarity on which modality do you start with, or is there a structured way? I got confused at what point did you move from the X-ray to the multimodal MRI concept, because it seems a long journey from the imaging perspective, structurally. Would you clarify how is the best way of approach so that we minimize resources but at the same time provide the most probable diagnosis?
Thank you very much. One of the important things we usually get is from the history. If you have a relative who has had a fragility fracture or osteoporosis, we usually take those seriously and consider them earlier. Two, there are fractures which show signs of actual osteoporosis. That's a distal radius fracture, fracture of the neck of femur. Well, good, he showed the things index. If somebody has a Ward's triangle, osteoporosis, we usually take those seriously and consider them earlier. Body of the vertebra, because we know very well in spine that 80% of the weight of a person goes through the body and 20% through the appendix, the back. So they usually start getting actually collapse. But again, if we look at age, after menopause, they start losing weight. I mean, losing the bony architecture. So from around 60, 65 years, people are supposed to start looking at it. Mostly with the ladies and also by around 70 with the men. Because by 80%, people have lost a significant chunk of their bone. Thank you very much. Then on the issue of what we are talking about, he tried to cover virtually most of the imaging which you would use and choose from. If you take just a normal X-ray and you look at it and look at the trabeculae, you are able to see something, and then because the cortex becomes thinner and the medullary canal becomes larger and the trabeculae start disappearing, then you can decide whichever you have and you'll get an answer. Thank you very much. I think you can add a few things.
Thank you very much. I think you said a bit of what I wanted to say. You know, let's say for instance now, what can we use as a screening tool for osteoporosis for our patients? We said that the World Health Organization and so many professional societies agreed that DXS scan is actually the gold standard. So today it is regarded as gold standard. But we saw that it's actually a 2D representation of a 3D human anatomy. That inherently is a challenge, is a weakness, despite the fact that we don't have it. And we are probably soon having it. So as he said, one, you use what you have. Number two, remember imaging is an exploratory procedure going beyond the history and your clinical diagnosis. So we said, use what you have. We have x-rays. There are so many things that we saw can actually aid you to say, this is an osteoporotic bone. particularly in the commonly affected bones, as Prof. Alex said. So if you see that cortical thinning and probably even fracture, the bone replacement, as we saw, you have the transverse trabeculae being replaced and have vertical trabeculae. So we saw that we have ultrasound capacity to do quantitative bone mass assessment. So does the CT, because for the CT it's actually software. And the more you pinpoint to the rightful bones, you get an approximation of actually what the bone mass is. And we saw it's either normal, osteopenic, or osteoporotic. Thank you.
Another question from the other side. Okay, orthopedic surgeon.
Thank you so much. Mine is a comment. It is really indeed a very good faculty. Thanks for choosing the best speakers, sir. I'm an orthopedic surgeon, yes, for those of you who don't know me. Another thing is that it's a subject that encompasses every person in the practice and the science of bone and muscles and hormones. Indeed, having arranged the speakers from endocrinological point of view about the subject, then coming to the professors we have here who talked about the basic sciences on how these hormones work on bones and muscles, and let alone the investigations that we always need. It's indeed a very good one. Thank you so much. My concern goes back to how this subject becomes a public challenge, a public health challenge. It's indeed a very big challenge, and as you said, is there any better time to start this clinic? Indeed, in some places, you'll find national foundations, national osteoporotic foundations, because this is something that affects everybody across the board. And it's a multidisciplinary subject that requires interventions from all levels, be it clinicians, be it the government, be it the policymakers, that is to say. As we speak now, as I say that this is, especially in orthopedics, let's say, let me stick here on orthopedics. As we speak now, we've got ladies lying in our wards, waiting for surgery, and the ones we've just received actually only today. And these are ladies 86, one is 86, another one is 80 years old, who came last night, and they're waiting to be fixed. I like the comment that has been done by Professor Butera and Professor Rudachem about, and then it was also emphasized about, in terms of screening, screening people who are likely to get even very dangerous fractures. There are windows of opportunities to pick up these things and start treating early and avoid actually these fractures such as the spine vertebral fractures and neck or femur fractures that are really, really, really debilitating to our patients. As Professor Butera mentioned, he said that it belongs to nobody, yet it's for everyone. We see this across the board, and it is more meaningful when you see patients not very far away from here who get neck or femur fractures, and it is a death sentence. A death sentence. Somebody who initially had a distal radius fractures and was not treated ends up with a neck or femur fractures, and given the resources, given the availability of implants, given the expertise in the peripheries here, somebody qualifies to go. And again, as it is a public health challenge, once you get these fractures, like neck of femurs, the mortality rate is more than 30% in 1 year subsequent to the fractures. I like Professor Rudachemga, who also mentioned about the men that are not included in the menopause, in the subject of menopause will be a subject of another time. You know, men are at 2 times higher risk of mortality than women for those who get the neck of femur fractures. So I really emphasize that it's really a very big public health challenge, and each one of us here should go home and think about it. Not only a clinic, but we really need to engage everyone across the board and help these ladies as well as men. I thank you so much.
It's becoming much bigger than what I thought. Okay. The anesthesiologist wants to talk.
Okay, I'm asking a question as someone who does pain management. We have patients who are having overlapping conditions, like in this age of osteoporosis and having myofascial pain. So in myofascial pain, we recommend to the dietary recommendation to decrease the dietary food, which means we are targeting on the calcium decrease. And then there is another condition that, recommends them to have more calcium. So how would you advise on that? Because you have those patients. Thank you.
Good. Let me just say something. Another question? Oh, yes. Before you come in, let me tell you something. Actually, yesterday, I was invited to talk much more broadly about menopause to the public. I think the time has come. Maybe I will call upon you again, dear friends. Okay. Yes, Doc, please. Anyone? The question? Have they answered it? No, it was an observation. Oh, okay, good. So, to whom? To Professor. Sir.
That certainly is a challenge because, dairy products are the easiest source of dietary calcium. And so in that circumstance, then calcium supplements would be in that particular situation. If you recommend decreased dairy, then substitute something else. And there's many different ways to get dietary calcium with a lot of supplements. They grind up seashells and chalk and get it into that way. But that would be the recommendation. There's a lot of other foods that have calcium, but not nearly to the same extent as dairy products, and so that's always been a challenge. You need to eat a lot of kale to get a lot of sufficient dietary calcium. So that would be where supplements would come in.
Is there another one on the other side?
Thank you very much for this nice presentation with our respectable professors. I'm going to do business. I was wondering, today we quantify easily bone marrow density with different CT machines, or new machines. But I was wondering, in the future, rural areas, if we cannot imagine this DXA versus CT, because in a rural area we need especially to quantify this kind of osteoporosis. So I'm wondering if there is any advantage on DSA than CT on accessibility of machines. Business.
Question for me.
Yeah, for you.
And they're talking about public health, correct?
Yes.
So we should talk to the Minister of Health. Okay, that's very good. I think at this stage, sorry, question two? Oh, goodness me. I think we're not in a hurry for refreshments because it's not a hotel. It is our home, so stay around. Okay.
Thank you, Doctor. Thank you for this wonderful presentation. I was having two small questions. The first one, I will address myself to Prof. Randolph in regard of menopause management. We do sometimes receive a patient in late perimenopausal periods, complaining of those vasomotor symptoms and not yet completely reached their time of menopause. So, Prof, I wanted to know if for this patient we shall start hormonal replacement or not in terms of to relieve these vasomotor symptoms and the other clinical complaint of the patient, especially in their sexual life. So the second one I will address to other professors, whether orthopedists or radiologists. For this patient with menopause, bone densitometry may be used as a screening test, or we do it when the patient is already affected. Because I received some patient, Dr. Karakira, I wish he should be here because he's the one most likely. I don't know where he's picking them up, but he's bringing many to me. So should we use that test as for each and every patient in menopausal period, whether she is or not under treatment, as a screening to see if there is no bone damage yet, or we can use in case we receive the patient already affected? Thank you.
I'll tackle the first one. As I showed, that you can demonstrate bone loss before bleeding stops. We've documented that for up to 2 years sooner. And so when the symptoms happen, which suggest that the overall estrogen levels are going down, absolutely treat the symptoms when they happen and just figure out the right way to do it so that she doesn't have bleeding issues. But you don't need to wait until bleeding stops. Because remember, the definition of menopause is last bleeding a year later, and if you wait a year after she stops bleeding, you've already lost a significant amount of bone with the auxiliary loss. You do not have to wait. Pass that on.
Maybe let me try to reply to your question. First of all, I would like to thank you, Dr. Subira, to organize this conference. To thank you also, distinguished professor. I think this is a conference where we can learn a lot from both sides. On our side, we are, let's say, in the side of the business. I think this question is orientated to that. We learn a lot from this. And part of that, I think it is also a social responsibility to support this kind of event. For every event that you will have in this kind of situation, we'll be there to support. And during this meeting, I was doing my marketing, my business, application. And what we understand is that, let's talk about client. Our client is the woman of 65 years who is losing the age, who has historical fractures, if I understand well, to resume. Maybe for which we have to also monitoring the therapeutic. What is, let's say, the size of the market? We have in Rwanda population 30 million people. 45% of the women. In these 45% of the women, there are 5% of women of 65%. So this is what I'm looking as a client, if I can talk about business. Correct? So it means that we have a potential of 500,000 patients for you, and 500,000 clients for us. Just to summarize, just to caricaturize, not making the things complicated. So we have 500,000 patients that we need somehow to screen in the country. And it will be increased over the year. We live longer, so means this quantity of patients will increase. So it is really something that we need to take in consideration as soon as possible to have this DXA in the country. That must be a matter of priority, not only for the business, but for the women. We need to make sure that women at this age can get the best treatment. So, in terms of budget, if you compare to X-ray, CT, MRI, I'm not sure because we do not have yet this machine in the country. Maybe I will give opportunity to one of my colleagues which is in France. We can have maybe say something about that. He has more experience than me. But I think that it will be a price between a good X-ray, a very good X-ray, and in the middle of a CT scan.
Yes,
That will be, let's say, the average cost. And this is something which is affordable.
I have my answer.
Last question. I think there is a female among us. Madam, do you want to ask a question?
No, I was just saying. I thought you were really answering.
Okay, no, wait a bit. Yes.
I just wanted to say thank you for this gathering and discussion for an important.
Have the device.
So I was very happy when I heard that you started a menopause clinic. Actually, I have been sending you patients to the menopause clinic. And then, so every disease needs a champion. And again, thank you for being a champion for menopause and also osteoporosis that we have forgotten about. Yeah, so for most of my patients, as have been said, are patients who have severe osteoporosis. Some people who have already fracture and who are diagnosed with severe osteoporosis and who come for treatment and follow-up. Maybe I have seen very few who have been diagnosed with osteoporosis during imaging for other purposes. Yeah? Otherwise, most of my patients are with severe osteoporosis, so we need to educate healthcare professionals about screening, about treatment and follow-up, because there is also a gap in the treatment, because for some I see they are just on supplements of calcium and vitamin D. Some are just given for some months bisphosphonates and it's discontinued. So we need ownership of the disease, where we can send to, where patients would be followed and taken care of properly. So I just wanted to say thank you for this and then for taking the initiative.
Should we stop here and then justify the presence of this man here, because if you don't talk, we won't be collaborating with you anymore. So can we?
If, maybe if he is online, the colleague who is online, we can listen to him for a few minutes.
Okay, can you put him online? Yes, somebody talking to us from Paris? Yeah. Okay.
It's here. Sorry. Yeah. Bring it. It's very good.
Oh, yeah, yes.
It was needed by yesterday.
These kind of fruits, I didn't want to mention price, but I think that around 150,000
should come.
They can hear us. Yeah, they can hear us. Do you have to use the microphone?
You can't do it.
Good afternoon, Florian. I don't know if you can hear us. Florian, can you hear us? Yes. Est-ce que vous nous entendez? Oui, on t'entend faiblement, mais on t'entend. Peut-être tu peux parler un peu plus fort. Sorry? We can hear you. So, thank you for your patience, Florian. We have been making you wait for a long time, but the discussion was very intense. Oui, on t'entend, Florian. Oui, beaucoup mieux. Merci pour ta patience. It's okay. Les discussions étaient très intenses, mais je pense que bon.
So, I can start?
Oui, on a dépassé les limites du temps. We are, but I think
Okay.
that.
So I don't know. Okay. So thank you and good afternoon, ladies and gentlemen. Thank you to welcome us. Good afternoon also, doctors and professors. I don't know if you see the presentation that I'm sharing.
Yes. We can see, Florian. Can you hear us?
Okay, I think that there is a lapse time between what I say and what you are hearing. So I hope that I can start and that the time will run also. Thank you to Transfer Technology Rwanda to invite us to make a short presentation about IDTech, who we are and what we do. And then we will make a focus and zoom on osteodensitometry with my colleague, engineer of application, André Bianco. In some words, IDTech was created in 2003 by Jean-Claude Morin, precedently founder of several companies specialized in the manufacturing of X-ray equipment. And our company is created in 2003, and we become a leading OEM company in Europe. And currently, we are extending our dealer network. We are located in south of France, in Nîmes, between Montpellier and Marseille, and we are historically focused in Africa, and mainly West Africa, Sub-Saharan Africa, and now we are extended in East Africa and South Africa, but also opening some market in Latin America, Europe, and Asia. Our company is certified ISO 9001 and 13485, and we are working with private radiology doctors, private clinics, hospital, civil security organization, army hospital, NGOs. And as you can see, as you can see, we are also working with the French civil field hospital with the civil security. I do fast because I know that the cocktail time is coming, and just to inform you that we have a different solution for X-ray system. We have radiographic and fluoroscopic system for stationary. Okay, remote control table, many used. And we have also radiographic system as U-arm, I-arm, chest bone rooms with either tube stand on floor, on rail, or ceiling stand on the top. We have also dual synchronized column and stitching stand. So we have good solution. We have medium solution under the major one, but with the same quality. We are offering also mobile solution for radiographic and fluoroscopic, so with the C-arm, and also for mobile X-ray, I mean analog and digital system, manual, to bring the X-ray to the patient bed in manual and motorized version. We are also offering mammo device, cone beam CT, and DEXA osteodensitometry. Our equipment embeds some radiographic flat panel detectors for rad, but also for fluoro. And then we have also arranged to update and retrofit analog mammo device into digital. We are also offering acquisition workstation and diagnostic workstation and PACS solution. So our company is able to support you on the whole technical department of your clinics, from acquisition to diffusion and printing. Now I let the relay to my colleague André to make the quick presentation on the bone densitometry device. I think that many of slides that we prepared in previously are already mentioned by doctors and professors who spoke just before us. So maybe we will pass quickly to not spend your time. Thank you very much.
Hi everybody. Thanks a lot to pass time with us. This DXI is a 64-channel bone densitometry to make analysis to BMD. Florian, tu peux passer les diapos? Yes. You know about osteoporosis. And this device help you to define if these patients are osteopenia or osteoporosis. Next. So the peak bone is between mid-20s and decrease in lifetime. Next. Florian, on passe. Okay, you know about this. Next one. The risk factor of osteoporosis. One is smoking, alcohol, get low in calcium, family history, menopause, the most risk factor for the woman, and Caucasian or Asian race. Next one. With the DXA, you can have the T-score or the Z-score. We define the risk of bone size of this patient. Next. Next one. The test result. Normal, osteopenia, or osteoporosis. Next. This device helps you to analyze in quick time the BMD with a non-invasive exam. Next. With the high-quality images, you see the BMD image or the DR mode image. We have a great quality. Next. The scan time for the acquisition of spine, femur, forearms, L spine is shortly, and make a quick exam and a quick result for the BMD, T-score, and Z-score. Next one. This image can be sent to the PACS with the BMD image and the result report. You can share with all doctors in the world to share it. The device is first open bottom design. Shortly, a compact device. We can place in a short room, and it don't need a great infrastructure for put it. Yes, next one. These results showed you your shoulder report. Next. This is the specification of this this device. Next one. Next. The X-ray radiation for this device is low than a day of X-ray natural exposition. So it's very, very low about all the device we can compare with CT or other. Okay. Next one. Thanks. Thanks a lot.
As you can saw, unfortunately, French people are not speaking very fine foreign language, and we apologize for that. But I can assure you that our system, our device, our product are better quality than our English.
Yes, of course.
Voilà. André, explain you how is working the bone densitometry device, and I think that you, during all this conference, you can understood the advantages of this solution to help patients and help doctors to can diagnose the osteoporosis and to can follow also the evolution of bone density on bones and osteoporosis during the life of the patient. It's true that the menopause is one of the key events on which we have to detect and start to follow deeply our patient. So I don't know if you have some question about technical using or how we can use also in French if we have to share some experiences. Andre has a lot of experiences, so maybe it would be in better position as me to can answer to your question.
Thank you, Florent. Thank you for your presentation. Very much appreciate. Let me say that also in French. Merci beaucoup pour ta présentation. En tout cas, elle a été appréciée par tous les participants. Elle a été très courte et bien concise. On a eu les informations qu'il fallait sur la machine. This is the first session. I think that we are going to have more. This is the first conference that we are talking about now. Menopause clinic. I think there are some following up of this session, and we shall come back to you for more explanation and more information. Thank you very much for your time. And let's schedule, let's say, another session. Yeah. I don't know if you can hear me. Il y a un décalage.
Ouais, ouais, je pense qu'on peut s'arrêter. Tu peux arrêter ça, je pense. Tu peux arrêter ça.
ID, can you support?
Can you stop? Can you stop? That's fine. Good to leave this. Okay, friends, I think